Thank you everyone being here. And what we're going to talk about is we perform a study looking at the Accuro and compare to traditional palpation method and see if it does really help us to improve our proficiency, our ability to successfully place a spinal block or not. Let's see. So for disclosure, the study was previously presented at ASA last year at a symposium. The study itself is independently conducted and is not supported or funded by the company itself, but just like Brandon, we were invited to talk here, and we do receive an honorarium for giving the talk. As the learning objective, we'll do a very quick review since Brandon has talked about a lot of the basics behind ultrasound and application of the ultrasound for neuraxial block. We'll do a quick review looking at the pros and cons in terms of using the traditional palpation of landmarks versus a conventional ultrasound in terms of placing your block. And then we'll do a quick review as to look at how you would use the Accuro, and mostly we'll talk about the study itself and what did we find in terms of comparing the traditional method versus the using of the ultrasound. So some of the reason and the goal of the study, as we know, we have used traditional method for many, many years and very successfully. However, particularly in obese patient or difficult or anatomy patient, it's becoming difficult and challenging to really palpate the spine, as well as the intercostal line. And especially with the prevalence of obesity getting significantly higher in the recent decades. And nowadays, it's not that uncommon to see 50, 60, or even 70 BMI at our institution. So the 50 and 60 is our new 30 BMI nowadays. And furthermore, as Brandon has mentioned, there's a number of studies that have looked at when you do palpation, the level that you estimate tends to be much higher than when you do it by fluoroscopy. And in addition, when you do palpation, you really don't have any information on the depth of your needle placement as well as the trajectory of your needle. Now, traditional ultrasound, as Brandon has talked very nicely about, it does have a number of studies that have shown that it reduced time, reduced the number of attempts, and provide a much more accurate level. However, just like the raise of hand, not everybody uses it. As I look at it, there was a number of reasons. Well, with the conventional ultrasound, the machine tends to be bigger. It's quite inconvenient to try to get the machine to the labor room or even to the operating room. Just the logistic of getting it sometimes will be longer than your procedure time. And since I'm not in the area of trained as an ultrasound person doing all the blocks when I was trained, so I'm not as smart as Brandon. So it takes me a lot longer to do the conventional ultrasound technique. And also there are a number of studies that look at the learning curve of conventional ultrasound. Actually, it does require number of times to practice and experience to properly interpret. And it also requires subjective interpretation of the scan and where it is and so forth. And so with all those, therefore, it sometimes limits our preference of using the machines in our everyday practice. So the goal of this is to find a device that is easy enough to use, convenient, and have minimal learning curve, or almost a novice can just pick it up and use it a couple times, figure out where the buttons are, then should be able to use it without really having to go through a long learning time. So a quick background on the traditional palpation method. So as we see that when you compare the typical palpation method, you feel the intercostal line, and then you go to palpate the spinous process. But typically in palpation, the level is typically 1 or 2 levels above where the fluoroscopy would typically show. And this is one of the slides that Brandon has shown earlier. So when you find the location with the ultrasound, the screen will actually give you the overlay. Therefore, you don't, I think of it as more like a GPS. You don't really have to think about what are you looking at as much. You basically follow the dotted line and follow the direction, and then it will give you the space and the images to place your needle. So what we did on the study is we hypothesized that using the Accuro ultrasound would reduce the time and also reduce the number of attempts to successfully place spinal block. When we define successfully placing the spinal block, we define it as the time we insert the spinal needle to the time that the CSF return from the spinal needle. And this is in comparison to using the traditional palpation method. So in the study, it is an IRB-approved study with written consent, and we planned it on this particular study to have 60 evaluable subjects, and the inclusion criteria are BMI over 30, and they are all for non-emergent elective cesarean delivery under spinal block. We randomized them into two groups. One group is the palpation only, and the other group is ultrasound only. And so in the palpation group, they would not have any information about the ultrasound information, and also in the ultrasound group, they would not palpate anything in the back. So once the ultrasound marked the location, then the needle will go the exact location as marked by the ultrasound. So in the ultrasound group, the ultrasound by the Accuro device is done by 4 providers, and these 4 providers are novice to ultrasound, and also they did have about up to 10 times practices on a phantom gel or on a human volunteers, but they actually had not used it on an actual procedure until they actually start the study. So all the spinal blocks are placed by providers that are experienced in placing spinal block. Either they are at least a CA3 or above level. So based on our institution, in the studies, all of these providers have at least 150 neuraxial block experience before they participate in the study. And the spinal block are all performed in a sitting position. And so in the palpation group, just like we talked about earlier, you will feel the intercrestal line go to the midline, palpate for the spinous process, and then estimate either L34 or L45 level and mark it to decide to place your needle placement. So in the ultrasound group, just like Brandon has talked about, you started with the ultrasound on the left-hand side on the screen, and you go from above the gluteal cleft and go upward, and you can see on the left-hand side of the screen, the line is whited. So first you find midline and you move cephalad, and then the screen will actually guide you to try to match that dotted line, the top triangle to the second triangle on the left-hand side, so that you'll be midline. Once you find midline, you may be on top of the spine. So that's why you can see on the left-hand side, the screen shows a blue image, which is actually the spinous process. So you keep going up, and then once the interlaminar space is identified, you will see the screen, the image on the right-hand side. And at that point, what you do is, so this is the little locator, and it fits onto the head of the probe, and you can just slide it off, and you can see that indentation, see it, the 4 marks marked where you want to put your needle. And at the intersection, I just use a pencil mark to show you the intersection of the 4 mark is where you want to insert your spinal needle. And as you do the ultrasound, you will actually notice the angle of the probe, because as you change the angle, you may actually looking at the spinous process instead of the interlaminar space. So that's why it's important also to recognize what angle it is. Therefore, you have the insertion location and the approximate visual angle of the insertion of the needle. The primary outcomes we look at is the time from spinal needle insertion to CSF return, and the secondary outcomes we look at the time it takes to do the palpation or the time you take to do the ultrasound. And we look at the number of passes to success, the number of redirection, as well as we ask the patient for a satisfaction score and a pain score immediately after the procedure. As to after the procedure, what do they rate from a scale of 0 to 10? So the statistic we did a priori sample analysis, we will anticipate to look at a 20% difference in terms of time to be clinically relevant. And so we estimate with the power analysis to be 30 patients per group at least in order to show that difference. So these are the results, and we actually enrolled 62 subjects. Out of those 62 subjects, we randomized them into 2 groups, but 2 of them were actually excluded in the study because of protocol violation, and therefore we left behind 30 in the palpation group and 30 in the ultrasound group. And the demographics of these patients are basically similar in the age, BMI, and gestational age. The gravity and parity did show a statistical difference. However, we don't feel like the gravity and parity would have made a significant difference in terms of our primary or secondary outcome measures. Now, in terms of the primary outcome, we look at the time when you insert the spinal needle to the time you actually see CSF return. And we find out that the median time between the palpation and ultrasound group was statistically significant difference. We take 50 seconds for the ultrasound group to get CSF versus about 122-second median time to get CSF. And when we calculate the 95 confidence interval, you can see the two groups are actually not overlapping, which suggests that difference are indeed existing there between the two groups, the differences. And when we look at the palpation time, and we did find that it was also different. The ultrasound takes actually a little bit longer than the palpation. Ultrasound takes median time is about 33 seconds versus the palpation group is about 23 seconds. So what we did is we include the palpation times or the scanning time to the time for the spinal fluid return, and the total time, that's what we call it, and it remained statistically significant different, meaning that the ultrasound group or the Accuro group was statistically shorter in terms of completing the procedure to see spinous fluid return. So besides doing that, what we find is that since the sample size is somewhat on the smaller size, even though we will probably power analyze it to measure the difference. So what we did is we look at the time. Each group, there are two groups. Group 1 has 30 times, group 2 has 30 times. So we use what we call the Hodges-Lehmann estimator, and each sample in group 1 will be measured with the different times difference of group 2. So group 1 and group 2 has a time difference for each sample. So sample 1 will measure a difference to sample 1 through 30 of group 2. So we repeat that procedure, then we'll have actually 900, 30 by 30 sample differences in the population. And with that, we actually find out that the median differences between groups are 60 seconds for the time to obtain CSF. And the total time also is 53 seconds difference between the two groups, favoring the Accuro ultrasound group. And also the 95% confidence interval also suggests that the difference are indeed existing because they are both stay within the positive range of the calculation. Now, as we look at the number of passes and also the number of direction, you can see are statistically also different with the Accuro group, with both pass and redirection are slightly less than the palpation group. However, when you just look at a single pass without ever needing any redirection, meaning you just put it in and straight in, the difference are not statistically significant, meaning that even though numerically they are different, the ultrasound group is 30% with a first pass without ever any redirection, but the palpation group is 13.3%. However, if we just measure a pass without needing redirecting the needle, the success rate is about 60 versus 33% with a statistical significant difference. So in summary, then the ultrasound group tends to findings suggest that the time takes to find the CSF is shorter. It takes a little bit longer to do the scanning. However, the total time remains shorter with the ultrasound group. The pass and the redirection are also less with use of the ultrasound. So these are the results from the experience from the patient side, and the verbal pain score was actually not different, but the satisfaction score was slightly better in the ultrasound group as compared to the palpation group. So as we look at any new devices, any new technologies, ideas, we need to know what are the limitations. You have to look at what are the limitations within it before you apply it clinically. So the sample size is smaller in this particular study, but the differences were statistically different, and the study was probably powered. So we need to take a look, see in a bigger study, in a bigger sample size, if the results remain consistent. And secondly, the behavior of these providers during the spinal block could be unknowingly affected because they are being watched or observed and timed for the procedure. Now, patient's anatomy and movement and its variation sometimes is hard to totally control in this particular situation. And one thing that was critiqued as we were looking through the study is the BMI of 30 is, like we said, the new BMI of 50 and 60 is the new 30 nowadays in a lot of places. So, but in our institution, if the BMI is really high, then a lot of the provider will prefer to use CSE rather than a strict spinal. So therefore, that's why we decided to stay with 30 to start with. And also in the device itself, the Accuro, the maximum depth is 12 centimeter. And the pattern recognition software also could be affected as the tissue depth are getting deeper and deeper. So in conclusion, the ultrasound Accuro device seems to have shortened the time and decreased the number of passes required to obtain CSF during your spinal procedure, and they tend to have a higher overall satisfaction. And larger clinical trials should be used to confirm the results that we find with this study, and probably also should look at different levels of providers, different ultrasonographers, as well as different patient groups. So we learned that we can take a lot of pictures, images, and help with protrusions in the neuraxial block. So sometimes we wonder what are some of the effects when we have too many images. And thank you, and hope you all have a good meeting. And this is my daughter, youngest daughter, and I'm glad to tell you, and also my wife is glad that I did not name her Tinkerbell, but actually we named her horse Tinkerbell though.